speaker is from the States, Preston Parry. Preston Parry is a reproductive endocrinologist from Mississippi Medical Center and has clinics in Mississippi and Louisiana. He's a past president of the Society of Reproductive Surgeons and the chair for the Mississippi section of the American College of Obstetrics and Gynecology. He's also the inventor of the Periscope, which has been a breakthrough in fertility testing. Thank you.
Privilege. All right. So, it's a privilege to speak today, in part because I got to change 90% of my slides last night to respond to everything said yesterday. So this is going to be a different talk from what I had originally, but at the same time, we're going to have a lot of fun. So, to rethink yesterday's conclusions, true idiopathic reimplantation failure is very rare in select populations, but at the same time, explained recurrent implantation failure is more common than we wish. So we have to say that, again, as alluded to, we have a lot of people who don't have 3 euploid embryos. We also have a lot of people trying to get pregnant who don't have a morphologically normal uterus. By the way, for ideals, when looking at the exclusion criteria, lifestyle, maybe after everything we saw, we do not have to worry about lifestyle modification, even though stress, smoking, drinking don't help, even though drinking is how a lot of people get pregnant. At the same time, for talking about the ideal, I'm in Mississippi. The average BMI I have is 34, and so therefore 20% of my patients would be excluded from the Proteus study for a BMI over 40. And finally, as we think about the ideal woman, beyond her being Italian, we have to say that ultimately, as you look at the Gill study, only less than 0.1% of women actually fell into that category. So we have a lot of people who aren't necessarily fitting the models. The gap between the ideal and the real is meaningful. So, we have things that we have to address, and we, of course, are looking at molecular, the visible, the socially visible, and, of course, those issues that need testing, but the overwhelming emphasis is going to be on the passenger and the vehicle, the person and their home. So, to talk quickly about what we look for macroscopic uterine factors, what we can see, we, of course, have several issues that we want to address. Now, again, I've eliminated a lot of what I was going to say in order to address what hasn't been addressed, but to take from Dr. Van den Bosch's talk yesterday, a good ultrasound is enough and I can prove it. Well, I would argue that a good ultrasound can sometimes be hard to find. This person had a D&C for polyps, and she was told on subsequent ultrasound she was normal. Now, we're all getting palpitations with that. The reality is, while she was told she was normal by her REI, the sonographers look at that and say that is heterogeneous, irregular, cystic, and the hysteroscopists among us also wouldn't transfer an embryo into that uterus. So, for what we're looking for inside the uterus, which was my original topic, we have what matters, what do we look with, what makes us suspicious, and how can we be fooled? And I think I've completely removed the things on what matters and how much, because I think we've done that very well by many capable authors. So I'm going to focus on the other 3. Now, first of all, we have to say that technology evolves. This is the gap between what I was given as a hysteroscope in university and what, as soon as I moved to private practice and could buy my own, for the difference. These are both people with endometrial cancer, by the way. And the gap between a 720p hysteroscope and a 1080p one is enormous. In fact, for me, I had difficulty performing vaginoscopy with the old one, and with the new one, vaginoscopy is effortless, and I see so much more for endometritis and details. Now, why does that matter? Well, when we think about how technology evolves, this was alluded to yesterday, Insight, only 80% could successfully cannulate the cervix. With good modern technology, our nurse practitioners can do greater than 80% with vaginoscopy. That's better than the physicians in the Insight study. So we have an era coming where nurse practitioners or junior staff are going to be doing better than the papers we allude to. And when we can do this, 91% of people have mild to no discomfort, less than a pap smear. The average hysteroscopy is less than 5 minutes. And the fixed and disposable costs are for us $30 to $40 per procedure. That's including lifespan of your hysteroscope, your saline, your tubing, and everything else. So if you can do this accurately, gently, safely, quickly, affordably, I think we have to say that 3D ultrasound is becoming the new standard and it should be effortless, but then so should hysteroscopy. And for all of us, for diagnostic hysteroscopy, if you can't do it faster than saline infusion sonography or insemination, and by lower level providers, that day is coming. So they should be complementary and interdependent. So, if this is what we're having to do, we are going to have to teach junior people, not just cater to the experts, but we have to have it so everyone is able to do these evaluations. This is an access to care issue. Now for that video, it was originally showing that there was a polyp in there, and you could see actually, looking at some of the trilaminar disruption, or the margins, and it had distinct mobility had it played. Let's see if these are playing. Okay, this though, so that was something you could see well in ultrasound. These though, again, I would say if you are being sensitive with your SIS, for example, in that case, to see in the exact same picture a few minutes later with hysteroscopy, if you could pick those polyps up with your SIS, you probably have a sensitivity at a meaningful expense to specificity. So I would argue that there is some things with nuance and subtlety that can sometimes show up with hysteroscopy, or at least, again, to untrained eyes, to unexpert eyes, hysteroscopy can sometimes find things that you might miss with sonography. With expert eyes, of course, that's different. So for polyps, again, what will burn you is if they are small, lateral, cornual, lower uterine segment, particularly if you use a balloon for your SIS, which will displace it, displaced endometrium and grooves. I think we have to remember that a lot of people have instrumentation that can then masquerade as a polyp when in fact it's actually normal endometrium that's been moved for things. And I can even see that on hysteroscopy, where you can actually see a asymmetry to the endometrial layer at the point of the displaced endometrium for things where you can be fooled. By the way, I don't think we've addressed it at all, but polyps are paradoxical. They probably are not obstructive. You can see the bubbles disperse around them, not interfering with patency. Size doesn't matter, but tubal proximity does in some studies, and they decrease IUI and spontaneous rates, but not IVF. You can come up with complicated answers such as glycodelin interfering with fertilization and tubal transport, but not affecting implantation to reconcile that, but it's probably just that we need better data. For looking more at endometritis, what to look for, you can find it in very prominent cases, SIS, for things like that. And it's certainly heterogeneous. Endometrium, fluid, increased vascularity can make it suspicious. But as has been alluded to, multiple good talks, it is focal. And it'll be in part of the endometrium and not, and the more subtle the findings, the harder it's going to be for you to diagnose on sonography what is blatantly visible with hysteroscopy. This patient with recurrent implantation failure, you can see again that it's present in some places, not in others. You can see the vascularity. And by the way, this person with multiple failed transfers was told she had a normal uterus. That may look like a sperm there. That is, of course, a polyp. It was dismissed as floating debris, didn't look at vascularity. So this is, again, something that has been missed for many people. So watch for in subtlety. I think endometritis, which this person had as well, can even advance with DNC to even Asherman's. This person had 6 failed euploid transfers and was told by 2 different REIs that her uterus was normal. And of course, while with sonography, you have to be looking for the breaks in the endometrium, cavitary asymmetry, bridging and filling defects. Again, it was instantly obvious with hysteroscopy. So I think, by the way, for sonographic pitfalls, if the adhesions are filmy, lateral, and thin, you can miss it. This is a person where that left corneal adhesion would be very hard. I'd miss that even with 3D imaging. I would just say I didn't have the perfect image. And this was not a person with implantation failure. This was a G5P6 and a gestational carrier. So also, this did probably not affect her fertility. By the way, plug, pressure lavage under ultrasound guidance where you distend the uterus. People have to remember that overstretching the uterus can be painful. The filmy adhesions that can be swept with a hysteroscope often can be done far more gently for things, but both can be effective. For leiomyoma, and by the way, this was a person told she was normal on ultrasound, and of course, the expert sonographers here would never say that, and they would not have missed the type 1 fibroid, where she had 3 subsequent failed euploid transfers. Obviously, there are many things that we have to look for in describing fibroids on sonography, and ultimately, I think there are things, by the way, I mentioned for hysteroscopy, you can actually start displacing a fibroid with your hysteroscope at the diagnosis to then, if you are not doing see and treat, to start facilitating and making it easier for when you do an operative hysteroscopy. There's some opportunities there, but ultimately, you can miss subtle fibroids. I think that 3D ultrasound will help more with this. This was a person without classic recurrent implantation failure. It was a queer couple, 10 therapeutic donor inseminations, and they missed that very small fibroid that was right there on ultrasound with SIS. And that was obvious, and she instantly conceived after removal. Maybe she got lucky. I do think but small fibroids grow into big ones. We have to discuss when we would actually remove them on the continuum, but ultimately, the more nuanced and rich your imaging, sonographic or hysteroscopic, the more you will be able to find things. So things that can burn you, again, where you are fooled, shadowing often throws things off. The axial uterus, by the way, of course, for all of these will throw things off on sonography. Postmyometrial healing changes, adenomyosis, sometimes masquerades as fibroids, and of course, hysteroscopic infusion pressures. There will be a lot of times where it will look as though it's intracavitary, and of course, if you don't have low pressure, you can be burned. For congenital mullerian anomalies, by the way, this was a person told by MFM and REI that she was normal, or actually the REI did hysteroscopy and said there were a few adhesions by the left cornua, and they lysed them, and then told her she was fine. Well, she had 2 subsequent miscarriages in a 25-week delivery. By the way, no one had noted that her grandmother happened to have uterine didelphys. And this is what we found actually at our hysteroscopy when all the imaging modalities done before had said that she was normal by MFM and REI. And I think this comes back to the fact that when we keep looking at our studies, we talk expert hands, and unfortunately, a lot of people are not getting expert care. And the reason I also allude to this is this was a person with recurrent implantation failure, and by the way, she was an OBGYN and her husband was an OBGYN. Neither of them knew that they had a constricted cavity which could have been picked up by either sonography or by hysteroscopy incredibly well. And we did a widening of the uterus, and again, that she ended up getting successful with the first transfer. The point being, though, I think there's some capable people in the room who are already looking at the Y-shaped uteri and other dysmorphic uteri. But if we are still debating the relevance of the septum, even though I'm convinced, by the way, I don't find that the TRUST trial, the control group there does not generalize to my patients. I would say that, if we are having trouble there, we're going to have a very hard time with addressing evidence-based data for the dysmorphic uteri from sample size and power. For the final issue, I will actually save this for another speaker, but 3D is essential. Trace endometrial and external contour, and never forget the cervix. Got to be aware of the bicolicin going in. But hysteroscopy, again, while having value and showing what you get into, you definitely will need sonography to guide you, and never do a septal incision without knowing if there is a degree of fundal cleft. You can't you have to distinguish the septate from the indentations for the bicornuate. Finally, for retained products of conception where you can be fooled, this looks like a relatively normal uterus on simple ultrasound, but the problem is you can't see too much on the endometrium for things. You do SIS, a little bit more posterior irregularity, and of course, with hysteroscopy, there is quite obvious and meaningful pathology that can be seen. Endometrium that's isoechogenic will fool you, and in fact, I've been fooled. This recurrent implantation failure patient, for me, this is what I found. So she delivered July of 22. I did this hysteroscopy January of 23. Her general OBGYN removed these products of conception April of 23. Well, this is what I got 2 weeks ago. And I think after the first or second implantation failure, you might be able to say those were fine. I probably shouldn't have waited till the third implantation failure to do a second look hysteroscopy to find that not all the products had been removed at her operative hysteroscopy. So that one is on me. I think the isoechogenic endometrium can fool all of us, and the older I get, the more I think we should do second look hysteroscopy. We'll skip over the isthmocoel and adenomyosis and all of these for what is within the uterus. We have great talks coming up on these. But I think, in quick summary and to conclude, uterine optimization can't offset aneuploidy any more than euploidy can offset hysterectomy. Both your imaging and your high-quality embryos matter. When we look, we have to test in a way that is user-proof. It is not the experts that is giving people implantation failure. It is often lower-level providers who may not have as much familiarity with nuance. And finally, we all have to know where our strengths are, but we also have to know where we're more naked and vulnerable to know our weaknesses as well. Thank you.